Well, good morning, everyone. My name is Sergio Bueno. I'm from La Majore Hospital in Mendoza, Argentina. And today I'm going to be presenting chylothorax induced by dasatinib in a patient with a chronic myeloid leukemia. So, our patient is a 49-year-old man with chronic myeloid leukemia. Is of 3-year evolution that has been in treatment with dasatinib for 2.5 years. He has a chromosome Philadelphia positive and P210 positive, and the patient is in complete remission. And he had a history of mild hypercholesterolemia. So our patient had in one of the checkups, had a dry cough, a weight loss of approximately 5 kilograms, and he referred to us some dyspnea. So we decided to do a chest CT scan, and in our chest CT scan, we saw that the patient had a bilateral pleural effusion, and when we saw this, we spoke with the patient, and we decided that we're going to expect this and see what happens. The patient then came up 2 months later, and he said that his dyspnea was worse. So this time around, we did a chest X-ray. In that chest X-ray, we saw that he still had that bilateral pleural effusion. So in this time around, we said, okay, we're going to speak with surgery, the thoracic surgery team, and they said, okay, we're going to place a right pleural drainage tube. And with that, we saw that we had 1,200 milliliters of milky fluid. And with that fluid, we said, okay, this patient has to be hospitalized and we have to study. So we admitted him in a common ward. And with that, we sent this pleural fluid to analyze. And what we highlighted was that triglyceride levels were above 110 milligrams deciliter, and cholesterol levels were way below 200 milligrams deciliter. So with this, we arrived at the diagnostic of a chylothorax. Okay, so our patient didn't have any history of trauma or thoracic surgery. And the first CT scan that we did in the first checkup, we didn't see any malignant thoracic lesions. So the only thing we had to think was that this may be an adverse drug reaction. And the only medication that our patient was taking was dasatinib. So we went to check what were the adverse events, or at least the most frequent ones, and we saw that pancytopenia, skin rashes, and pleural effusion was the most frequent one, with this latter one being between 28 and 33%. So, okay, but we didn't find anything about chylothorax. We didn't see anything on prospect, we didn't see anything on vadomicum. So, okay, we're going to do a little more digging, and when we went and did a little more digging, we found that there were, at least at that time, 15 other case reports about a direct association of chylothorax and dasatinib. Okay, now we're getting somewhere, we thought, but what are we going to do? But there isn't any therapeutic management for this because there aren't very much case reports. So the only thing that they all had a common agreement on was that we had to suspend our dasatinib. So that's what we did. We suspended dasatinib, and we switched to imatinib for 100 milligrams a day because our patient was in complete remission and we wanted to keep it that way. We gave him a light chain fatty acid diet, and the pleural drainage started to decrease slowly, but it started to decrease. It never got below 100 milligrams deciliter. So we discharged him after 16 days, and we said, okay, we're going to do outpatient follow-ups and see how he's going. Slowly, it started to decrease even more until it got below 100 milliliters in 24 hours. And after 4 months of staying with that pleural drainage tube, surgery said, okay, we're going to take it off. So they removed the drainage tube, and we then saw him in another checkup, and we did this chest X-ray, and we saw there was no recurrence. So we thought, okay, we got it. But as a conclusion to all this, chylothorax is clearly something very rare with limited knowledge. But we think that this is something that's now rare because there isn't a lot of case reports, and this is something that we're going to see even more because we're starting to use these drugs even more, and with time, there are going to appear even more adverse events. And case reports like ours sets a precedent to support the therapeutic management decisions in future cases and to stimulate diagnosis suspicion in patients with similar presentations. So this is our references, and thank you for listening.
Well, thank you very much. In a good fashion, you are a minute ahead of time. Once I start talking, we fall behind time immediately, but that's okay. I will take the privilege or opportunity of having this microphone. I'm always extremely impressed how much fluid you see on the CAT scan versus how much you see on this X-ray. I couldn't dream you get 1,200 milliliters from the chest X-ray, which you showed us. Quite amazing. I have another comment. How often you learn something what you could remember and use practically within 5 minutes? And we learned it from you, so thank you very much. We have a content expert who was asked to start the discussion, for which we'll hopefully have for 4 minutes. On this occasion, we have Professor Florence Rufus from Belgium.
Thank you. So I've never done this exercise here before, and I'm certainly not an expert on chylothorax and dasatinib, but I did hear your case with a lot of interest. So I guess I begin by asking a few questions. Is that correct?
Or comment, or criticism, or praise, whichever one you want.
Well, congratulations for a very clear presentation. I do have a few questions. I was struck by the fact that you gave him imatinib after dasatinib. While imatinib is generally a first choice, dasatinib would be a second choice, and I would have assumed that dasatinib was given because he had been resistant, perhaps, or refractory to imatinib. Can you comment on that?
Well, and actually, this patient was a patient that was in the service of hematology, and they started with dasatinib. That was their first treatment. To be honest, when we chatted about this, they just said that it was easier to find this drug instead of imatinib. It was weird. It's true. And we didn't find anything to say, okay, we should have changed for some other type of drug because the mechanism is the same, actually. So they talked to people in Buenos Aires, and they said that they had a patient that was similar. It had pleural effusion, not chylothorax, and they switched the drug from dasatinib to imatinib as well, and they had good results. So they say, go ahead and try that, and we'll see what happens. That was
okay. So it's
really happened.
A question of availability, because it would
Exactly.
be unusual. Because, I mean, perhaps a tricky question, but do you know what the mechanism of imatinib resistance is that makes people then shift to dasatinib in these kind of
actually,
leukemia?
what we saw actually when researched that, it's not really known exactly what the mechanism is for a pleural effusion between imatinib or dasatinib or any of these drugs. There are some theories, but there isn't actually something that's strictly proven that tells us why this is happening, especially chylothorax. There even isn't a theory on why that's happening.
In a true McMaster spirit, when somebody asks us a question and we don't know the answer, we're asking back, would you know?
So yes, I do actually.
Oh, here we go.
So there's a little pocket, tyrosine kinase pocket, where there are mutations in some patients with chronic myeloid leukemia, and then the imatinib just can't fit in that pocket anymore, and that's why you generally shift to dasatinib. And concerning the mechanism, I think that it's really because the imatinib and dasatinib are targeting the tyrosine kinases like PDGF receptor alpha beta, which I think have a role in effusion, in permeability, I believe. But anyways, thank you very much. Very, very interesting.
Any other comment from anywhere in the audience or your bell? We are very thankful for a very strong start. Thank you.
Thank you.